Although uncommon, fungal infections are not rare and you will come across them sooner or later. So, you should attend this session to find out all the details that you need to know to be able to deal with the ones that come your way. Hi, this is Dr. Mandana Donahue from Oral Pathology 360, where we help you stay updated and connected with everyone and everything related to the diagnosis of oral and maxillofacial diseases and their management. Last week, we received kind contributions from Dr. Nasser Said and Dr. Bhuvan Nagpal. A great many thanks to both of them. Coming to today's lecture, we are delighted to share with you one by Dr. Yamely Ruiz on the topic of uncommon fungal infections of the head and neck. Dr. Yamely Ruiz Vázquez is Professor Oral Pathology, Oral Medicine, and Oral Biology at the School of Dentistry, National Autonomous University, Mexico. She has considerable interest in the subject and has acquired considerable amount of training and also has made great amount of contributions. With that short introduction, I welcome you to the Oral Pathology 360 recorded lectures. I do hope you will enjoy watching. Please stay with us, and if you haven't done so before, hit the subscribe button. Thank you.
Good day to everyone. Before I start, I want to thank the Oral Pathology 3600 team for the invitation, and a special thanks to Dr. Manzana Donahue. I'm glad to be here today talking about the uncommon fungal infections of the head and neck. The objectives of this lecture are: first one, make an overview of the uncommon fungal infections, and followed by describe some helpful tools for the histopathological diagnosis. I also describe some classic and some recent diagnostic tools for the identification of these fungal infections, and finally make the discussion with some clinical cases. About the contents of this presentation, first we have the introduction. I will talk about the zygomycetes, about histoplasma, about blastomyces, and finally make the conclusion of humans are exposed to fungal spores daily, but usually not producing any harmful effects on their health. The reason of this is because most of the people are immunocompetent people. Most opportunistic oral mucosal fungal infections are due to Candida albicans. However, another species such as Coccidioides semitis, Histoplasma capsulatum, Blastomyces dermatitidis, Paracoccidioides brasilensis, Aspergillus, and Rhizopus can also be found. The occurrence of opportunistic fungal infection has increased significantly over the past 2 decades. This increase can be attributed to the growing number of the immunocompromised patients. The most related diseases related with these fungal infections are diabetes mellitus, renal insufficiency, and HAV. However, other diseases like leukemia can also be related. The most common presentation of the fungal infection of the head and neck are the invasive fungal sinusitis. However, other presentations in oral cavity and in skin can also be found, like principally the presence of ulcers. First, we talk about the zygomycetes. The zygomycetes after Candida albicans is a rare infection, but with the group of the rare infections are the most common human infections. And the most common affection is the rhinoorbital cerebral mucormycosis. In this group of zygomycetes, there are included some subspecies like Rhizopus, mucor, and Rhizomucor. There are the 3 most common subspecies. However, another species less common like Cuniganella, like Absidia, and Sansecnae can also be found. The more affected sites are the sinonasal sites. However, another sites like central nervous system with the rhinocerebral mucormycosis has also been found. The orbital affection, pulmonary, systemic, cutaneous, and gastrointestinal has also been described. Mucormycosis is an angioinvasive fungal infection, and its incidence cannot be measured exactly since there are a few population-based studies, but multiple new studies have shown that the incidence has increased. This prevalence being described approximately the 0.14 cases per 1,000 of population. This disease has a rapid growth and are associated with patients with immunocompromise, principally diabetic patients or patients with diabetic mellitus not controlled. The reason for this is that these fungi have a rapid growth rates in the city of neutropenia and diabetic ketoacidosis because the acidity increase the iron presence and the hyperglycemia promotes the organism growth. In the last 2 years, this mucormycosis has been associated with a complication of COVID-19, but as I said at the beginning, also is related with patients with has all type of immunocompromised. Clinically, the mucormycosis or the zygomycetes infections are associated with a necrotic area that can be an ulcer at the beginning, and this ulcer has a rapid growth with bad borders, bad defined borders, and the necrotic background. This is characteristic because this fungi has angioinvasions. That is a common finding that results in the thrombus formation and the necrosis of the tissue. With the past of the couple of days or weeks, these ulcer transform with a perforation. And as we saw in these images, the palate and maxillar bone are the most affected sites. However, some sites like mandible can also be affected. About the histopathological findings, the characteristic is found broad, pauciseptated ribbon-like hyphae. These hyphae measure between 5 to 15 microns, and the characteristic of these hyphae are the presence of the 90 degrees angles. This is a better important difference between another fungi that can also be has the same characteristic, but the angles in Aspergillus, for example, are acute. The diagnosis tools that we have for this are first the KOH. However, the KOH is a quickly tool, but the sensitivity and the specificity are low. The biopsy is also the most common diagnostic tool. However, the biopsy all the time has to be complemented with another tool like the culture. Culture has been described as the gold standard. However, in the last year or now, the nuclear ribosome and ETS, that is the internal transcribed spacer, and specifically the 28S ribosomal RNA sequence, has now considered the gold standard for the diagnosis of the mucorales. So it's a new tool. However, the cost could be um, could be not good for all the patients. Another tool is the galactomannan test that is negative, in contrast with Aspergillus, that it is positive. Here we have the case presentation, have two cases. First is a 56-year-old female, and the second is a 54-year-old female, and both with diabetes mellitus. In the right side, we saw the one of the cases that this woman that we when we asked for make some movements, we saw that the eye of the right side has in movement. The reason is because the disease has progressed to the orbital area. In the left side, we saw this clinical image with ulcer that has a necrotic background that is characteristic of the mucormycosis. This color that could be yellow at the beginning, but with the pass of the days could be brown and black, and could be painful or not. In this case, that was painful. And in the CT scan, in the actual view, we saw most eating area that has bad defined borders, and is characteristic of this disease. The histopathological findings for both cases has the presence of these IFIs, with this IFAS has the angles of 19 degrees that is characteristic, and the contrast with aspergillus that the degrees are 45, that are there are acute degrees, and these IFIs are combined with neutrophils, some plasmatic cells, and lymphocytes. The presence of histiocytes that has also could be finding. So here we saw this microorganism that is an IFI with the presence of this 19 degrees angle, and some bacteria of the background. The treatment and prognosis for this disease consists in the surgical debridement and combination with the administration of intravenous amphotericin B. For patients in cases with the amphotericin B has been resisted, we can use some drugs like prosaconazole and isavuconazole. And it's very important to make the control of the predisposing factors. Also, in the histology, it's important to make some stains, special stains with histochemical, because with hematoxylin and eosin is not enough to make the diagnosis. As we saw in the image, it was necessary to make another techniques like the periodic acid shift stain and gomery metamine silver stains can be helpful for confirm the diagnosis, but the biopsy is not the gold standard. For this reason, it's important always complement with another tool like the culture, and or if the patient can pay, actually make the detection by molecular techniques. It's important to consider also the differential diagnosis with another diseases like lymphomas, epithelial cystic carcinoma, squamous cell carcinoma, and another fungal infections. The second fungal infection is histoplasmosis. Histoplasma capsulatum causes this disease, and histoplasmosis is endemic in the world, and specifically in some places that are related with environmental niche that includes places with nitrogen-rich soils and with attic with bird or bat droppings. In these cases, the patient inhalate the fungal spores and germinate into yeast. And the alveolar macrophages and the neutrophils are unable to clear the infection, so the yeast persists within the macrophages and spread to the lymphocytes. And here have two ways. If the patient is an immunocompetent patient, the T cell activation promotes the formation of granuloma. But if the patient has immunocompromised, so the disease has a dissemination. Clinically, the sites more affected are lungs, mediastinal, lymph nodes, skin, oral cavity, and bone. And it presents like nodules, deformations, or ulcers, but the characteristic of this ulcer are the granular background. This is very, very important in the clinical for this disease, and the formation of granulomas. If the patient has pulmonary involvement, other symptoms like fever, fatigue, night sweats, dyspnea, and weight loss can also be found. Histopathologically, this disease is characterized by the presence of small, uniform, and oval structures. These small structures has a narrow basic body chest with eccentric archon-like nucleocluster within the histiocytes intracellularly. And the granulomatous immune response are also be found with the presence with multinucleate giant cells. As the same that occurs in the another fungal infections, it's very important to make some another tools, histochemical tools like gomorrhea, metamine, silver stains, and periodic acid shift stains for highlights the organism, because hematoxylin and eosin is not enough. For make the diagnosis, the biopsy is and very helpful key, but also we have another tools like the screening for the antigen. This antigen can also, at the beginning, the first time, this antigen has been detected in serological tests. But now it's better and it's cheaper to make the detection of this antigen in urine. Also, the culture is a very good tool for make the diagnosis that complements the biopsy result. But we know that the culture, we have to wait at least 2 days for has a diagnosis. And now we have the molecular confirmation using the gem proof. This is an allogenic proof that has an hybridization assay that now is a routinary use to confirm the diagnosis. So it's a very good way. It's a new molecular confirmation for the diagnosis of histoplasmosis. Also, the PCR test can also be used. However, the PCR detection is not approved yet for the FDA. About the case, we present here a 46-year-old male. We saw clinically that is a skinny patient. This patient has the work of this patient is a fissure. And in these photographs, we saw that in one side of the skin has a little swelling on the maxillary zone. Here in the intraoral image are the more important findings. We can see an the presence of ulcer, but this ulcer characteristically has this granular background that it's very important and is characteristic in some fungal infections like histoplasmosis. So in this case, the patient presents symptoms, pain, uh, and refers months of evolution. And that at the beginning was smaller, as we saw now in the image. So we can see this area. It's a huge ulcer in the palate zone, and with this zone of communication with the maxillary sense. But the most important finding is this granular background. With these characteristics, we have to consider another clinical diagnosis like squamous cell carcinoma or like lymphoma or another fungal infections also. But in the biopsy and the histological characteristics, we saw the proliferation of these histiocytes. These histiocytes was complemented with the presence of some neutrophils, plasmatic cells, and lymphocytes. But the most important finding are that in the cytoplasm of these histiocytes has the presence of these little structures that was hard to show with just this hematoxylin and eosin. So we decide to perform this periodic acid shift stain that the microorganisms are more evident. So we have the presence of these small and round microorganisms, and with the Gomery metamine stain, silver stain, we also saw the presence and the proliferation of these microorganisms, small, round, and are positive. So these findings are consistent with the diagnosis of histoplasmosis. However, as I said, this diagnosis has to be completed with the culture or with another tools. About the treatment and prognosis, the itraconazole is a drug that is used for the treatment of this disease. However, amphotericin B is added for several diseases. The treatment has a time to 6 weeks to 12 months. And as I said, we have to consider another differential diagnosis, clinical diagnosis. Talking about blastomyces, the blastomyces cause the blastomycosis. So the most important is the blastomyces dermatitis. This causes the blastomycosis and is a chronic pyogranulomatous inflammatory disease. Pyogranulomatous because the neutrophils are very important in this disease. There are soil organisms associated with most areas near riverbeds at Midwest, like South Central and the South areas of U.S., particularly in areas surrounding in the Ohio or Mississippi River. However, can be present in other countries, like Canada and Africa and also India. The blastomycosis has two presentations: the pulmonary and extrapulmonary disease. The pulmonary disease is the most common and also represent the 90% of the cases. But the extrapulmonary disease can also be found. And in this extrapulmonary disease, we have the cutaneous affection, the gastrointestinal affection, osseous, genitourinary, and to central nervous system. About the affection, cutaneous affection, that occurs in skin and mucosa. The characteristic lesion is the presence or verrucous ulcerative lesions, wart-like, that has demarcated borders and are elevated areas. So it's very characteristic of the skin affection for blastomycosis. About the histopathological findings, as I said at the beginning, we have the pyogranulomatous inflammation that is composed by the presence of neutrophils, infiltration admixed with epithelioid histiocytes, and the granulomatous formation that translate in the finding of giant multinucleate cells. In the skin and mucosa, the pseudoepitheliomatous hyperplasia is a very common finding. But the most important is the presence of the gest. It has an uniform side and has a refractive round gest that a high power may show cell contents with the refractive cell wall, but often this material wash away during the process. And it's very important also make some histochemical stains like PAS and GMS. Also, another histochemical stains like musicarmine can also be helpful. And in this case, it's important to make the musicarmine for make the difference with Cryptococcus, which is the most important differential diagnosis for the histopathological findings. In the Cryptococcus, musicarmine is very, very positive, but in blastomycosis is little positive. And also another stains like Fontana Mason can also be made because the presence of these gests of these microorganisms can mimic as hemosiderin or melanin. For the diagnosis, it's important to make the biopsy. And the biopsy, we can show the findings that I described, but the culture as the last diseases is very, very important for make the diagnosis. And also the antibody detection test. This antibody detection test, we have two ways for do it. The first is the immunodiffusion that use purified bed dermatitis E antigen. That this test has a low sensitivity and low specificity. But another way to make the antibody detection test is using the enzyme immunoassay, use the BAD1, that is most sensitive approach that the another. However, we have a cross reactivity with another infections like histoplasmosis. So, as occurred in the last cases, it's important to complement the biopsy with one of these tools, the culture or the antibody detection. This is the case discussion for blastomycosis. In this case, we present a 42-year-old female with the presence of these plaques with ulcer in the central part, but the borders are very, very elevated and has a verrucous surface. So has the wart-like appearance that are described in all the blastomycosis cases. This is the same patients. The patients has more lesions, not only the lesion of the nose, has another plaques and ulcer areas behind the ear in the right and the left side, and this submandibular area also. The plaques was asymptomatic, has not another symptoms. The other symptom that the patient described was only a cough of a couple of months. The biopsy of the lesions of the skin was made, and in this logical, we saw this round microorganism that in the center has a refractive of the microscope, but in the center has a little particles. So the first mainly differential diagnosis is with Cryptococcus, but the difference, or one of the difference, is that the microorganism in Cryptococcus is bigger than it occurs in blastomycosis. And this is very, very characteristic of blastomycosis, the presence of this yeast that has a wall that is refractive of so on the microscope. This is a periodic acid shift state. And in another areas, we saw, also the yeast, but the spores. That was a very, very cute finding. Also combined with the presence of histiocytes and some neutrophils. And this is a high power, the presence of these yeast. It's beautiful, you know. We can see the wall, this very, very important finding, and the measure of these microorganisms is smaller than the Cryptococcus. And also we perform the GMS stain, and also was positive in these areas for this microorganism. So with these findings, the diagnosis of blastomycosis was made, disseminate blastomycosis. And I will say why disseminate if only we saw the lesions of the skin and can be extrapulmonary presence of this disease. So the patient referred a cough of a couple of months. So thorax radiography was made, and we saw the pulmonary affection on this. So was a case of disseminated blastomycosis. One important thing of the blastomycosis is that, in contrast, that occurred in another mycosis, in these cases, the patient not always has a disease that cause immunocompromise of the situation. So that is a very important key also. About the treatment and prognosis, the itraconazole is the treatment for election in combination with amphotericin B. And also it's important to make the consider the differential diagnosis, and specifically with another diseases like tuberculosis or sarcoidosis. So in conclusion, we can say that these diseases are rare, but are important to know. Also, the last case of the blastomycosis in Mexico, there are no reports blastomycosis since 1985, 87. So was a very, very rare finding. So are important diseases to know, but we know that maybe are rare, but in some places, in some geographic areas, could be more prevalent. It's important to consider in the differential diagnosis of another entities with malignancies, for example, lymphomas or squamous cell carcinomas. And the histological features are the key for major diagnosis. However, as we saw in the presentation, It's not enough with the hematoxylin and eosin. It's very important to complement with another stains, more specifically like periodic acid shift and gomorrhea methamphetamine silver. And always, the biopsy has to be complement with the diagnosis with other tests. Maybe the culture is the most used complement tool, but as we know, uh, we have now new tools like molecular tools that could be more helpful and more specifically than the and more quickly than the culture. So I want to thank again to Dr. Manzana Donowe for the invitation for this lecture. And I want to thank also to some of my professors, Dr. Beatriz Aldape, Dr. Ana Maria Cano Valdez, and Dr. Jerónimo Lazos. Thank you very much. If you have some questions, comments, or doubts, you can also write on the section at the end of this video. Thank you very much.
Thank you, Dr. Yamely, for that wonderful presentation. And thank you all for attending and for being with us today. You might also like to watch a video from our archives, which was a pre-COVID and COVID era update on mucormycosis, a diagnosis to management. It was presented by the combination of an oral pathologist and an oral surgeon. A very interesting webinar that is available on our channel, and you can always look it up. I hope you will enjoy watching it. With that, we shall say bye and hope to see you next week. Have fun till then. Bye.